الشيفنج يا جماعه. الشيفنج بيعمل منه تروما. If there is one expert technician will do shaving and he found some human papilloma virus and will shave it, it will give bleeding. He is not يعني non-minded with what is this. He will continue. Then bad sterilization for the probe may be transmit the HPV for the next patient. So if does we can cover the probe with something exchange like that? Do you remember disposable soap for the thermometer?
Yeah.
We can cover with cling film, very fine, very fine cling film.
I do that. I advise about that.
Yeah.
And always cover it and remove it and sterilize the probe with a piece of cotton with Sidex. But about the particles, I don't know.
I'd like to comment on using the smoke evacuator with hair reduction. There's a paper recently published that the particles that evacuated in the air is carcinogenic.
Yeah.
So it should be used.
62 compounds which are carcinogenic and toxins in the plume of the hair removal. So it has to be really taken care of. I think we have to move to the next topic, which is the pigmented lesions in dark skin.
Albert has joined us. If you'd like to ask his opinion.
Sorry?
Albert has joined us.
Albert.
If you'd like to ask his opinion.
Let us move to that because we are short of time. So for pigmented lesions in dark skin, Albert, from your experience, what is the most successful pigmented lesions in dark skin which can be treated with laser?
I mean, certainly lentiginous and freckling. I mean, that's easy, these epidermal lesions. Some lesions tend to recur, and that is a problem for any type of laser device, but it really depends on the pigmented disorder itself.
Okay, in this case, do you use the ablative lasers, Erbium-YAG or CO2, or the Q-switched lasers for those?
Oh, I use, in fact, only the Q-switch lasers for the pigmented lesions.
Okay, perfect. Peter, do you have anything to add?
I'm always a little bit reluctant to treat pigmented lesions in dark skin. I never use. I do use CO2 and erbium laser in lighter skin types for lentigo and freckles, but not in dark skins. And then I sometimes tend to use the Q-switched NEAC for pigmented lesions, which doesn't give you much absorption, of course, in the pigmented cells, but it seems to work. So that's actually what I do. I use the Q-switched or the Pico NEAC laser 1060 for almost all my dark skin patients, also for their dark skin or for their hyperpigmentation problems.
Okay. What about melasma? Do you treat melasma with laser, or you prefer to avoid the laser?
We tried melasma with the Pico laser, and it seemed to, but we are very non-aggressive to use that word, and we see some improvement, but not much, and it tends to come back also.
This is the issue. If the laser is going to be improving the melasma temporarily, and then there will be remission, whereas you can achieve the same effectiveness with non-laser modality, with something to improve the epidermis and bleaching agent and sunscreen. Why do you laser, which is relatively expensive? When do you laser?
Is this question for me, Akraf?
Yes, for you.
Yeah, well, the thing is that also with other modalities, with creams, etc., the lesions with melasma tend to recur, and people sometimes overtreat and get other problems from the hydroquinone, for instance. And also we use the triple therapy, as Albert also does, but we see some side effects from that. And now we have this Pico laser, which is so a short pulse length that there's no heat delivered. It's just the explosion of the pigmented particles, and we think we're quite safe with that. So that's why I'm using it.
So it's a sort of rotation therapy with the other modalities. This is what you say.
Also, yes.
Okay, good. Albert, regarding the melasma and the laser treatment, when do you go for laser, and when do you prefer to have other modalities than the laser?
Well, it's quite easy. I never use the laser anymore. We did for a certain period, we did a couple of studies, and we had some patients, especially the ones with darker skin types, of course, who also got post-inflammatory hyperpigmentation. But another issue is, I mean, it always comes back. And if there is a lack in the literature, then it is really for long-term regimens and the efficacy and safety of these regimens. And of course, there are many laser devices that can improve the hyperpigmentation in melasma, but it's a short-term improvement, and there's always a risk of worsening the hyperpigmentation.
Okay, thank you. I support that opinion, but let us hear the Egyptian experience.
Yes, our experience is first choice, the first pigmented lesions we have to use laser for it is nevus of Ota. Is the first choice and the only solution of the problem. For nevus of Ota, it's very effective and very excellent results and no recurrence. Since 20 years, I'm using this Q-switched laser for nevus of Ota and no recurrence at all. We can use it for lentigines, senile lentigines, solar lentigines, but informing the patient that there is recurrence in these conditions and we have to use sunscreens forever.
So, Abir?
Okay. We have a message. Not to be a laser specialist, this doesn't mean you should use laser in every dermatological application. You should follow the evidence-based medicine. And in melasma, the laser comes as a third or fourth line when other lines fails. And it comes as a transepidermal drug delivery of others. So it's adjuvant and the last one, not the first choice.
Ahmad, would you like to add something?
I agree definitely to what Professors Mona and Abir has just mentioned. For nevi, for sure, the rate of recurrence is less, but a good technique has to be performed in order to leave uniform appearance after removal of the lesion or dealing with the lesion. And the most difficult thing is the melasma in our dark skin phototype, especially with the uncontrolled use of OTCs, which sometimes creates ochronosis of the skin, which is sometimes difficult to distinguish from melasma. So for melasma, as Professor Abir mentioned, yes, laser doesn't come in the first place, and if you're going to use laser, this will be a Q-switch laser. If someone has a pico laser, definitely. And the technique, again, you have to choose the proper wavelength and the proper fluence and a good technique in order to be able to cover the whole lesion in the best manner.
I want to add something. In nevus of Ota especially, we have to prolong the interval between sessions up to 2, 3, or 4 months. This gives very well results, and because it takes time to be the particle to be removed from the area we are treating. And as we use Q-switch laser for melasma, I tried it many times, and now I didn't use it at all. I just may use fractional laser, especially erbium YAG with this dark skin, and use it as drug delivery for bleaching serum, bleaching creams after that, and inform the patient that this is a permanent lesions. She have to use bleaching creams till reach the normal color she needs or she wants, and then also sunscreens, it's mandatory.
Any experience with the tranexamic acid?
Yes,
oral?
yes, we have studied just
Yes, we compared the effect of the tranexamic acid in split phase study versus laser, and tranexamic acid proved to be better and cheaper and easy to use.
Topical?
Topical, yes, by intradermal. Okay. And sometimes people give oral, and sometimes it is given by Dermapen.
Okay.
Drug delivery, yes.
So I think the conclusion is that once melasma, always melasma. Patients of melasma have to know that they have to be keeping good care of the skin, just like diabetes and hypertension. The patient will not take the medication for 1 month and stop. This is a lifestyle. Sunscreen, taking care of the epidermis, epidermal barrier restoration procedures with the bleaching agents on and off according to what they use. I think it's much more important and valid than using lasers, which can be associated with darkening of the melasma or recurrence after they pay a lot of money. So this is the message, and this is what I really prefer. Now, the next topic or the next challenge is stretch marks, especially in dark skin. Albert?
Well, I am quite reluctant to treat them. I personally, I know the literature, and there are quite some studies showing improvement of stretch marks, and it depends maybe also on the stage. If it is still a lot of erythema, a vascular laser can improve that, but typically the erythema will improve spontaneously over time. But really the structure of the skin, I have tried different devices and I'm not really convinced, although I know the literature is out there. I don't know why.
Okay, thank you. So now, two things you don't touch with lasers: stretch marks and melasma. I hope the list is not going to increase.
I want to use.
Okay, Peter.
About stretch marks.
Yes.
Well, of course,
the video is on now. Thank you.
yes, I'm here with you.
Good. Stretch marks.
So no, stretch marks, they really work. They become smaller, and I use the fractional CO2 laser for that.
in dark skin?
Finally,
Fractional CO2 in dark skin?
yeah, also in dark skin, yes.
Okay, no
Actually,
PIH?
pardon?
No PIH? Post-inflammatory hyperpigmentation?
Yeah, we use, no, not so much. You see that, but of course we decrease the fluence, and also we put the points more apart from each other, and it really works. But people are not so happy with it because the end effect after several treatments is not so very good. Although I had one patient who was blind, and that's a very interesting story, and she was very happy with the result, because when she felt over her skin, it did feel a lot better. She couldn't feel the stretch marks actually, but looking at them in a visual perspective, they're still there. So this is also an area I won't touch with laser so much.
Okay. Any different experience from the panel?
Yes, with stretch mark red color, we can use,
Red.
if it is, yes, early stretch marks, we can use pulsed dye laser and give excellent results.
Okay, how many
But when it
sessions?
turn,
How many sessions, Dr. Mona?
according to the effect,
The effect. So you
okay,
go on with the
3
sessions?
or 4 sessions.
Three or four sessions. Okay.
The rubra,
And is it purpuric dose or subpurpuric?
it's subpurpuric.
Subpurpuric.
Because it is modulation.
Yeah, you want to stimulate the collagen besides affecting the
yes,
vessels.
yes.
Okay. Dr. Abir or Ahmed, do you have any input?
Yes, we have many papers about stretch marks, but it gives a better results when it is deep, there is atrophy and there is a depth. But if it is flat and the same of the skin, it will not give an effect. So I heard from someone, and you can tell me, who works in Canada, they said that they approved some type of tattoo ink which gives a color similar to the skin, so they can camouflage for this stretch marks.
I'm totally against this,
Okay.
because the dye sometimes change the color, and then it's becoming very difficult because the color they used is not going to be responsive to the laser. So it becomes gray, and then it's going to be very, very ugly. So, and there are some beauticians who are doing that, and I see disasters from that. So this is something which I really don't recommend. Now, it's really very important to be wise. 30 years ago, the physician was not being called doctor. They were calling the physician the wise man, al-hakim. And I think it's very important to be wise. The patient who is having stretch marks, first we have to diagnose, is this something to be treated or no? Sometimes we have to reassure the patient and tell her, you are in the pregnancy age and it's going to come back again, and just forget about it, moisturize the skin to avoid that, and that's it. Not every case is indicated for treatment. Sometimes the reassurance is the solution, and patients will respect us patients will be happy, and she's going to be confident that this is okay, it is in 80% of people, and we don't need to manipulate everything we see. Now, if it is there and the patient is not going to be getting pregnant again, and it is large areas of the body, I wouldn't touch it. How much I'm going to charge the patient to treat that in order to achieve improvement not more than 40%? I don't think anyone can achieve improvement in the stretch marks more than 40 to 60%. So I don't think this is going to be cost effective for the patient. So sometimes it's really very important to tell the patient what's the reality, what we can achieve and what we cannot achieve. I never use laser for treating stretch marks. Sometimes if it is in limited area, in a stable patient where there is no weight changes or pregnancy possible, I personally use micro needling radiofrequency with PRP, combination of those two techniques, which is not very expensive for the patient, and it's going to be on limited area. I never treat an area which is more than 40 centimeters square. Other than that, I don't think it is a valid thing. Prevention is better by using good moisturizers when there are weight fluctuations. So this is my message. Now the next topic, which I think it's important, is the scars. So we have different types of scars. We have acne scars, we have traumatic scars, we have sometimes element of fibrosis, and we have also fresh wounds which we want to prevent the scar formation. So Albert, if you are still there, can you let us know what is the best remedy in scars, whether it's fresh or old, with the lasers or no lasers?
Well, certainly lasers, I think, are a good choice for different types of scars, and you need to choose the type of laser really according to the type of the scar and also to the stage of the scar. I know that there was a systematic review 3 years ago of treating very early the scars, and it came up with that in the very early stage this treatment is effective. On the other hand, I don't think the evidence is that good to do that on a large scale. I'm not doing that very early because I think there are a lot of scars that will improve spontaneously. So I would overtreat a lot of patients. I typically wait until I see how the scar is going to look like, and then I will start the treatment depending on the type of scar, with different devices.
Okay, so the strategy of using the pulse dye laser within 7 or 10 days after the operation or at the day of removing the suture, which was published long time back, this is something you don't do? You don't recommend?
I only do that in very special cases where I know that they get hypertrophic scars, where they had that in the past, and where I can treat very early. I don't do that standard because I don't think I could convince my colleagues that I'm doing evidence-based medicine. I know that the papers are there, but they don't really look at the satisfaction of the patients on the long term, on quality of life, and these kind of things.
Mm-hmm. Okay, Peter, I think you have a different opinion.
Yes, I do.
Yeah.
I think it's although I agree with Albert, the evidence is not conclusive, and it's certainly the case that there's a lot more research being needed, and most probably there are scars that better are left alone. But in general, I think that that scars can be treated as soon as possible, because you will activate some substances in the skin that help healing the skin. Once you and it goes through heat. So once you heat up in whatever way you want this area, then you have a better outcome of your scarring. It heals faster, I think, and it will heal better.
Okay.
Can I add to that?
Yeah.
Can I answer?
Yeah.
If I look at the best studies there are that really have a prospective randomized controlled design, then there is indeed definitely a difference in the scar later on, but the difference is really not so very much if you use a POSAS. It is really very subtle, and the question is this really relevant for the patient, and are we not treating a lot of patients to get a little difference in the end? Mm-hmm. But that's open, the evidence is not there.
Albert, as you are still here, what about the old scars? I mean, if you have patients who is having old scar, whether it's acne scars or fibrotic scars, what are the type of lasers you use? Ablative, fractional, non-ablative fractional, resurfacing? What is the best tool? Yeah.
Yeah, in fact, I use, I think, quite a lot of different types of lasers. The fractional CO2 laser, I use pulse dye laser. I also use Q-switch lasers because sometimes the scars are also very hyperpigmented. And although that also improves with a fractional laser, but often not enough. And you can combine all those devices at the same session to improve the outcomes.
For me, this is a little bit critical because if I have hyperpigmentation of the scar, this is PIH. And we know that PIH does not respond to the Q-switched laser well, or sometimes we have refractory hyperpigmentation. So what is your protocol in this case?
Yeah, it must be, you know, the difference in color must be substantial.
Okay.
And you must not have a patient with a very dark skin type. But sometimes you have also patients with skin type 2 or 3, for example, from a burn scar, where really the hyperpigmentation is the most visible part of the scar. And then I think a Q-switch laser can do quite a good job to improve the visibility. But of course, it will have no effect on the pliability and the thickening.
Okay,
so
perfect.
I think you need to combine.
Okay, thank you. Peter, you are the master of using combination treatment for treating scars. So when do you combine the laser with injectables, whether fillers or toxins or whatever? When do you do that?
Oh, when scars are still in the process of remodelation, in areas where it's feasible, I always use toxin. So on the forehead or on the chin or on other body areas, I would go for botulinum toxin. And at the same time, I would use a laser, either a pulsed dye laser or a fractional CO2 or erbium laser. I don't think that the Q-switch lasers will do much on the healing process, but only on the hyperpigmentation. So that would be my protocol in conjunction with sometimes vitamin C, vitamin E creams, etc.
Okay, and if you're going to do the toxins with the laser, do you do it in the same session or before or after?
Yeah, well, of course it's preferable not to do it in the same session, but sometimes because of convenience for the patients, I do it.
Okay, perfect. So I think we are very short of time. So this is the last question, or the last case is the large pores. Before you leave, Peter, let us know what do you do when a patient is coming to complain of large pores?
I still have no specific answer for that, actually. With these fair type of skins, I would do some resurfacing, I think, some very superficial, like with the erbium yak or so. But, well, actually, I don't really know what would be the best. And I've tried several things, but, well, for me, nothing seems to work the best.
Albert, do you have an answer for that or comment on large pores?
Well, my experience is quite limited, so I really can't tell, but I think it is really very hard. And if I might go for a fractional CO2 laser.
Okay, thank you.
For me, I'd like to use the erbium glass laser. It gives a marvelous effect and it is non-invasive, safe in dark skin. So I recommend to use it.
Fractional laser. Okay.
Please, Dr. Ashraf. It will يعني keep it permanent.
No, yes, you're right. It's a sign of aging, so it will recur.
For me, I prefer in dark skin using the erbium, fractional erbium.
So fractional laser to stimulate the collagen. Ahmed?
I assess the patient first because sometimes it's due to hyperseborrhea, others are due to photoaging. So if with photoaging we go for ablative, for fractional resurfacing of the skin, non-ablative versus ablative with all the pros and cons. But if we're dealing with the case of hyperseborrhea, a low dose of systemic isotretinoin and mesobotox will help with such patients who are toxin in low dose.
This is very important. Now, everyone focused on the fractional laser to stimulate the collagen. Now I have a question for you. If you have someone who is having large pores, if you stretch the skin a little bit, does the pore improve? The pores improve. So this means that if we improve the skin elasticity, it's going to improve the pores. And the skin elasticity is coming from epidermal barrier function, which is good. So restoring the epidermal barrier function and decreasing the hyperkeratosis, which happens with photoaging, is going to improve the hydration of the skin. So the elasticity is going to improve, and this is going to improve the pores about 10–15%. Now, stimulating the collagen, if the patient is above 30, then loss of collagen, which starts to happen from the age of 20, can affect the pores and make it larger. So doing something to stimulate the collagen, whether it's fractional lasers or microneedling or whatever, is going to improve the pores. If we stretch the skin and the pores improve significantly, then doing something to tighten the skin also is going to improve the pores. So that's why it's really very important to think in a systematic way, and we are dealing with aging in many cases. If it is not hyperseborrhea, which is going to be treated by the isotretinoin and the topical retinol, then it is aging, and aging requires an anti-aging program which affects the epidermis, the dermis, and the subcutaneous fat to tighten the skin, to stimulate the collagen, to improve the epidermis, and this is going to improve the pores about 40–50%. And then there is a maintenance, because aging is a dynamic process, so also rejuvenation has to be dynamic. This is the approach for
And
the
should be
maintenance.
Maintenance for every 6 months. You can use you can make a session for this fractional laser or microneedling or
Of course.
whatever,
I just
tightening
is-
of the skin.
It is skincare more than something else.
Of course.
To maintain normal, healthy, good skin, luster,
Skincare is
elasticity,
something, but for
Yes.
example, for the past 10 years, I'm using the Nd:YAG, non-ablative, in order to stimulate the collagen every 6 months, 2 times per year, plus microdermabrasion, something like that, to improve the epidermis. So we can use those modalities to keep the skin in good shape, and it's not going to be a huge cost because it's 2 or 3 times per year for the patient. And after 10 years, the patient will be looking much younger than when we started. This is the anti-aging program, and it improves the pores significantly with no downtime. And this is the advantage of the microneedling radiofrequency over the laser, because with the laser we have risk of hyperpigmentation. But with microneedling radiofrequency, it is non-ablative, there is no downtime, and it's working really very well. I think this was the last.
effect of ablative is more acceptable.
Of course,
but
it's-
for fear of hyperpigmentation, we don't use it.
So I think this was the last case, and as I said, Albert, if you can just invite everyone here for the session of tomorrow about the Nd:YAG.
Yeah, thank you. That's a good point. We are having, the ESLD is organizing a session on the Nd:YAG laser. And in fact, what we are going to see tomorrow, and that's Paris time between 6 and 7 in the evening, we are discussing the different aspects of Nd:YAG laser treatment. We're discussing clinical cases with some experts, Professor Kevin Nouri from Miami and Professor Firas Al-Niaimi from London, together with Ashraf Badawi, Leonardo Marini, and myself, and Hans-Joachim Laubach. And I think it will be a great session. So please, if you're interested, look at the website of the European Society of Laser Dermatology.
Thank you, Albert. Thank you very much for being here today with us.
Please, Dr. Ashraf, before you close, please.
Yeah.
On behalf of myself and on behalf of the board of our Egyptian Society of Dermatology, the official branch of the Egyptian Medical Association, a lot of thanks for our professor, Professor Peter, Professor Ashraf, Mona, Abir, Ahmed Sadiq, for this very marvelous and nice, well everything, well done session, and this full informative session. Thank you for all of you.
Thank you. Thank you very much, Dr.
Thank you.
Mustafa. Thank you, Peter. Thank you, Albert. And thank you, Dr. Mona, Dr. Abir, and Dr. Ahmed. Thank you very much, all.
Okay.
Bye-bye.
Next session, please. Next session sponsored by Parkville.